So let's talk about the TCAs. If you're able to see the slides, what you'll see is I've got the ring structure here for imipramine, the first tricyclic, and pretty much all the tricyclics, they have the same structure. It's very similar. You've got 3 rings that are attached, and then you've got a chain down to a nitrogen and some methyl groups. And the tricyclic is the 3 rings, and that end part is the amine, and that's why a lot of the tricyclics have amine in their name, because of that amine group that's down at the bottom. And unlike pretty much every other antidepressant that we have, most of the tricyclics all follow this basic structure. They all look pretty much like this. They've got the 3 rings, they've got the amine group, and all the other antidepressants look pretty different from each other. So let's go over them. So I think when we talked about the introduction to the antidepressants, was talking about how these were kind of discovered through the exploration for histamine 1 antagonists. Diphenhydramine had been found, and they were looking for more. And then chlorpromazine, thorazine, the first antipsychotic, was found in 1954 while they were searching for histamine blockers. And I mean, chlorpromazine does block histamine, but it blocks a lot of other things and works as an antipsychotic. And then imipramine was actually found shortly after that. And so it was the first antidepressant that was found through this research. So imipramine, blocks histamine as well, but it also has effects on these other receptors that we talked about. And so there's a lot of tricyclics, but I'm just going to talk about the main ones, and the main ones that are still used, or were main ones that were used in the past, but maybe not so much anymore. Um, we categorize the tricyclics into 2 categories. So there's tertiary amines and secondary amines. And this is an important thing to know, because it can help you kind of gauge what the side effects are. The tertiary amines tend to act similarly to each other, and the secondary amines, they tend to have similar effects to each other. Not exactly the same, but similar. All right. And so, what does that even mean, tertiary amine and secondary amine? Now, remember, I said that there was the 3 rings that are stuck together, and then the chain, and then the amine group at the bottom. The tertiary amines have 3 groups hanging off of them. So they've got 3 alkyl groups attached. The secondary amines only have 2. And so if you look at, I actually have the ring structure in the slides for every one of these. And so what you'll be able to see is you can see those 3 alkyl groups on the tertiary amines, and you can see the 2 alkyl groups that are attached on the secondary amines. So what are the tertiary amines? So as I mentioned, imipramine, brand name Tofranil. It was approved in 1959. And then we had amitriptyline, or Elavil, in 1961. And then we had doxepin, or Sinequan, in 1969. Doxepin is actually very similar to amitriptyline, but there's an oxide in there in the central ring structure. And then there's trimipramine, or Surmontil, and that's from 1979. And that's actually very similar to imipramine, but there's another methyl group hanging off that chain. And then there's clomipramine, or Anafranil, 1990. It's very similar to imipramine, but it's got a chloride group on it. And then not a tricyclic antidepressant, but a tricyclic cyclobenzaprine. So that's Flexeril. That's the muscle relaxant. And so it's not classified as a tricyclic antidepressant. I think because it's not approved as an antidepressant, I don't know, maybe it might be similarly effective. I would have to look through some trials to see if it's ever been tested for that, but it's not approved as an antidepressant. I put it in here because it's got a very similar structure to amitriptyline, and that can help you kind of understand where the side effects are coming from on Flexeril, because it's a tricyclic molecule. And now we'll list the secondary amines. so the nitrogen with the two alkyl groups attached. You've got desipramine or norpramine, 1963. That's a metabolite of imipramine. Nortriptyline, Pamelor, 1964. That's a metabolite of amitriptyline. And then we've got protriptyline, Vivactyl, 1966, is a similar structure to nortriptyline. And then, even though we're talking about tricyclic antidepressants, I'm throwing tetracyclics in here too. And on this slide, I've just mentioned meprodoline and amoxapine, but I'm going to list several more of those. Sometimes these are classified as tricyclics. Some of them have more of a tricyclic structure, even though they are tetracyclic, basically 4 rings stuck together. Some of them are 3 rings, but there's a 4th ring that's not stuck on the 3rd rings. It's actually like down in the chain. And so is that a tricyclic? Is it a tetracyclic? Does it matter? Bottom line is they work in a similar way. So what are the FDA approved indications for these meds? Okay, well, they're antidepressants, so it makes sense that they are approved for depression. All of the ones I've listed are approved for depression except clomipramine. Clomipramine, I think a lot of you will think about it as the OCD med. That's actually its only FDA indication. It's not approved for depression. And then meprodoline, which I mentioned before, is actually not approved in the United States, so it has no FDA indications. Other than depression, only 2 other meds have any other indications at all. Imipramine is FDA approved in the pediatric population for enuresis or wetting the bed. I don't know that it's used that much. Typically, we try not to medicate kids for this. There's a couple other meds that are out there that are used instead of imipramine. So I'm not sure in today's world, like I'm not a pediatric psychiatrist. I don't think imipramine is used very often anymore, but it does carry that FDA indication. And so I think it's important to know that, especially if you're being tested on this information. And then doxepin actually has a lot of FDA indications. So depression, but also anxiety. So it's actually the only TCA that's approved for anxiety, though I could imagine that they would all potentially be helpful for that. It's got an indication for pruritus as well. So that's itchiness. And it's specifically a topical formula that's approved for pruritus. There's also a formulation of doxepin that's approved for insomnia. And then doxepin's also the approved for bipolar depression. I'm not a big fan of giving antidepressants to patients with bipolar, and we'll talk about this a lot more when we talk about the mood stabilizers. But just kind of know that doxepin has that FDA approval for the depressive side of bipolar disorder. But at the same time, it's never used for this. Maybe 40 years ago it was. In today's day and age, to be honest, these medications are rarely used for depression. They're typically more often used for their off-label uses, which is what we're going to talk about on the next slide. Because of all their side effects, to get the dose needed to help with depression, you're also getting a lot of the adverse effects. But at lower doses, we often can help with some of these off-label uses and not get as much of those adverse effects because we don't have to dose it quite as high. So what are some of those off-label uses? So a lot of pain stuff. So neuropathic pain, inflammatory bowel syndrome pain, IBS, functional dyspepsia, that's kind of upset stomach with unclear origin, chronic fatigue syndrome, the insomnia and pain associated with that, cyclic vomiting syndrome, fibromyalgia, migraines and tension headaches, prophylactic for that. Mostly amitriptyline is used for that. Post-herpetic neuralgia, so that's like after you've had herpes zoster on typically on the face, and it's causing a lot of pain. So the pain associated with that, they could be used. Sialorrhea, so that's excessive drooling, and I mostly think of that with clozapine causing excessive drooling, but it's so anticholinergic. To add another anticholinergic is often problematic. And we'll talk when we talk about clozapine. That'll be a whole lecture in and of itself. It's such a complicated medication. We will mention amitriptyline as like a fifth line treatment for the drooling. ADHD is another off-label use because we are getting that norepinephrine increase. Remember, I talked about how the norepinephrine is how the ADHD medications like Adderall and Concerta work. Well, these medications also have that effect. Not really used for this in today's day and age. I think it was used maybe when there weren't as many medications available. Remember, these medications are from the 1960s for the most part. And so back then, they were pretty much all we had. We had the first generation antipsychotics. We had the MAO inhibitors, and we had the TCAs. And so we have a lot of new stuff now. And so we're not really using them for ADHD in today's world. Diabetic neuropathy, so that's pain associated with the diabetes, nerve damage, and then insomnia. A lot of these medications are very sedating, so that's a common use that we use them for sleep. And then I'm going to go down through the receptors that are important for the tricyclic. So before we reviewed like all the receptors, so now I'm going to review the receptors that the TCAs interact with. So the serotonin reuptake pump, and something to remember is that the tertiary amines have a stronger effect on this receptor, except oxypin and trimipramine. The norepinephrine reuptake pump, the secondary amines are actually stronger on this pump. The 5-HT2A, remember blocking that causes sedation. The tertiary amines, except imipramine, tend to be stronger there. The 5-HT2C, remember that's where we have our weight gain. Amitriptyline, nortriptyline, and amoxapine, more so on that receptor than the other TCAs. The alpha-1, when it causes dizziness, the tertiary amines are stronger at that receptor. The histamine 1, remember weight and sedation with that one. Most of them affect that, except disipramine doesn't affect it that much. And then the anticholinergic effects. And I mentioned this a little bit earlier, but I want to just review those. So from med school, maybe you guys remember hot as a hare, red as a beet, blind as a bat, dry as a bone, mad as a hatter, full as a flask. And so, we're talking about causing a high temperature. We're talking about flushing. We're talking about blurry vision. We're talking about dry mouth, dry eyes, delirium, the Mad as a Hatter, that's the delirium, and then full as a flask, that would be, urinary retention and constipation. And so a lot of bad effects, like blocking the muscarinic acetylcholine receptor is almost always a bad thing, though we do block it for medicinal reasons as well. Sometimes to help with dystonic reactions from antipsychotics, overactive bladder, but at the same time, you have all these other bad effects. And so we're really trying to find meds that don't do this. And there's been a big push recently. I mean, I've been talking about this for years, not on the podcast, obviously, but in my practice and in my teaching. But it's really coming up like, hey, do not block these, avoid at all costs these anticholinergic meds. And this is a big reason why the TCAs have fallen out of favor, is because most of them have a strong effect here. The tertiary has more effect. Secondary and the tetracyclics have a much less effect here. So as you're kind of seeing as we went through those receptors, the tertiary amines are the ones that are causing they have more of the serotonin effect, but then they also have more of the side effects on all the things that we don't want. The tertiary amines act more at the norepinephrine reuptake pump and have less of these adverse effects. And so if you're going to use a tricyclic, unless you're worried about increasing serotonin, picking the secondary amines is typically a better option. And a big one is because of the anticholinergic effects. And then, as I mentioned before, the sodium fast channels, that's what an overdose where they become dangerous, leading to arrhythmias, seizures, and delirium. And then just and one note on half-life. Most of these are daily medications, but protriptyline has a really long half-life, 54 to 92 hours. The rest of them around 24 hours. So, you stop taking it, the effects are gone. But protriptyline, it's hanging around for several days. I've never actually seen protriptyline used, but I think that's an important thing to kind of know, is it's one of our long half-life meds, along with Prozac, fluoxetine, vortioxetine, Trintellix, and Abilify, aripiprazole, criprazine, brexpiprazole. Those are our long half-life psychiatric medications. So this next one, I've got a chart kind of just showing the numbers for what I just said. And so this chart, what it shows is each of the meds on the left column, and at the top column we have each of the receptors that I talked about. And then kind of the cross section is you see these numbers. And what do these numbers mean? Well, they're Ki values. And so what the Ki is how strongly does this med interact at this receptor? And so just as an example, let's look at amitriptyline. At the CERT, it's 4.3. At NET, it's 35. At 5-HT2A, it's 24. At 5-HT2C, it's 4. And so what this means is it's actually the lower the number, the stronger the binding. And this becomes important for lots of pharmacological reasons. Essentially, what happens is we look for the lowest number, and for amitriptyline, it's 1.03 at the histamine 1 receptor. And so at the lowest doses, we're just mostly hitting H1. We're not really hitting the other receptors. As we increase the dose, the next one would be 4, and so that's the 5-HT2C. So then we start to hit the 5-HT2C and have those effects. And as we increase the dose, 4.3, that's at the serotonin reuptake pump. And as you increase it and you increase it, then you start getting the anticholinergic effects, 13.8. And so that's kind of how all of our psychiatric medications work. They interact at a variety of receptors, and they have a variety of different inclinations to. I mean, that's kind of personifying them, but they interact with these receptors at different strengths. And so at lower doses, you're going to have less effect at some of the receptors, and as you increase the dose. So hopefully that makes sense to everyone. This is a concept that I'm going to go over and over and over throughout all of these podcasts, because it's really important to understand like why we're getting the good effects and why we're getting the effects that we don't want. So just think, you look at where the lowest number is and see, like, let's take another example. Let's look at amoxapine. Its lowest number is 0.5 at the 5-HT2A, and then the next one is a 2 at 5-HT2C, and then it's a 4 at D2. So it's actually an antipsychotic at a pretty low dose. So in addition to being an antidepressant, it kind of has some antipsychotic features. And so this can kind of help you see, okay, well, maybe I want to block H1. Which one of these is going to block H1 the best? And I want to avoid those anticholinergic effects. So, which ones have a higher number for that? But at the same time, you can't compare these numbers between meds. So when you see that clomipramine tightly binds the serotonin receptor 0.28 and imipramine is only a 1.4, that doesn't necessarily mean that they have a different effect on that receptor, because that's the lowest number for each of those meds. So clomipramine and imipramine are going to block that serotonin reuptake pump before they block anything else. And of course, if you took them both, which you shouldn't, clomipramine is going to outcompete the imipramine. So there are cases where we might be giving an antipsychotic, which also interacts with these receptors. And, if you've got two meds that both block the same receptor, whichever one has the lower number on the Ki would be the one that would be preferentially hitting that receptor. So what I would want to explain is that you're looking within the med. So if we look at clomipramine, what's its lowest number? That's what it hits first, right? And then if we were to combine meds, we'd look at, okay, which one of those hits this receptor stronger? And a big example of this is Abilify, aripiprazole, really tightly binds D2 more than almost anything else. And so if you switch, and it has such a long half-life, it takes a long time for it to fall off that receptor, and it binds so tightly that nothing else can. And so that's where it would come into play. With these, you're not really going to have that issue because other than protriptyline, they all have the same half-life, about a day. And so if you switched meds, you wouldn't have that lingering effect, right? And so that's how this, I think a chart like this can be helpful, but it's not as straightforward maybe as you might think it is. And I learn things about this information all the time. And so that's kind of how I understand it to work. So you have this and you can study it, and I break open these charts all the time when I'm deciding what meds to give to patients. This is a big factor I use. What receptor do I want to hit for this patient? Or maybe what two receptors? What med might give me that combination? Sometimes you have to use two meds, but preferentially better to use just one. And if you can find a med that is going to hit those both of the receptors that you think you need to target. And that's why I talked about like the effects of these on that other slide was, all these receptors have different effects. And so when we want to interact with, what are the patient's symptoms? What are they ailing from? What do we need to fix? And so we look and we try to find a med that is going to interact with those receptors preferentially to treat those symptoms, and then watch and wait, see what happens. And that's how I like to use this chart to try and make better guesses instead of just being like, oh, this person has this, I'm going to give the same med to every patient. Well, every patient's symptoms are a little different. Maybe they're a little slowed down, or maybe they have some sleep problems or some other stuff going on that would help me. Maybe I want to find a med that will fix both of these problems or three, right? So that's a little explanation of this. We'll talk about it later, and we're going to go through all these meds individually. So, kind of generally, and I think I've already mentioned this, what are the side effects of TCAs? It's all that stuff when you block those receptors. The big one, and just to kind of the big ones to think about: sedation, the anticholinergic symptoms, orthostasis, low blood pressure, sexual dysfunction, weight gain, lowering the seizure threshold, and the possibility of a switch to mania, which we have with using serotonergic medications. The reason why I don't advocate for using doxepin for major bipolar depression, because you can get a switch to mania. That's the reason why we tend not to want to use these. But there's some conflicting information on that we'll talk about when we talk about bipolar disorder. So those are the main side effects that I think of when I think of these medications. It's mainly the sedation and the anticholinergic effects. And remember, there's a lot of anticholinergic effects. And I'm going to cover that in even more detail on the next slide. And then the other one is the cardiovascular toxicity. And I only really worry about this in an overdose. You're not really going to be causing, severe orthostatic hypotension, tachycardia, bundle branch block, and arrhythmias at the therapeutic doses. This is for patients who accidentally or purposefully took too much, which is another reason why we don't use them that much anymore, because, hey, what are we treating here? We're treating patients that have suicidal thoughts and they're depressed. Do I really want to give them a med that they could kill themselves with? No, I don't. And so that's why, if you have a patient who like the suicide is like not an issue at all, and you've tried other things, these have their place. But if you have a concern that they might kill themselves, I think patients are under the understanding that if they overdose on any pill, no matter what it is, they could die from it, which is not really the case. Technically, yes, but you would have to take so much of certain medications to actually die of an overdose, that practically they're pretty safe to overdose on. and the SSRIs would be one of those. You can die from an SSRI overdose. It's very uncommon. You don't have to take that much more than the max dose of a tricyclic to overdose and die. And it's because of the cardiovascular toxicity. It's because of what the effects it has on those sodium fast channels. And so that's why if I'm giving a TCA, I'm extra careful. But at the same time, I'm often, when I do use these, I'm using them for their sedative properties or pain properties or something like that. And I'm using a very low dose. And so you might be using a med like amitriptyline that's max dose is 300 milligrams, and you're just giving them 10 milligrams a day. I mean, that's 30 times lower than the max dose. If you gave them a month's supply of that medication and they took the whole bottle, they would essentially be taking the max recommended FDA approved dose of that med. If you're giving them this med for depression and you're giving them 1 to 200 milligrams a day, then we have a problem when they overdose. But if you're just giving them 10 milligrams a day for sleep, the chances of overdose from taking a 30-day supply, it's pretty low. They may think that, and I want them to think that. I want people to be afraid to overdose, and you never know what's going to happen. You should never take a medication not in a way that it was not intended to, as it was prescribed to you. But I do feel safer when I'm giving those super tiny doses of a med like this, when I'm like, well, if they did happen to overdose, it would still be within the therapeutic dose. And so I'm less concerned. But of course, if someone did overdose, I would do the full, the ER would handle that. They do the full workup. And also, going through adverse effects, as I mentioned before, the tertiary amines have more adverse effects than the secondary. And then I want to talk about the anticholinergic effects in more detail. So, and I think this is really important because these are just so harmful. So, xerostomia, that's dry mouth. And I think, this is annoying to patients. They say, oh, I've got cotton mouth. I have to drink a lot of water. But I think what a lot of people are not aware of is this can cause dental problems, tooth decay, gum inflammation, a lot of dental problems from dry mouth. And so if someone says, I like the med, I can deal with the dry mouth, I just, chew gum or drink a lot of water, my radar still goes up and I'm like, I don't want you to get, dental cavities. We don't want to ruin your teeth. This is actually, so it's, I think a lot of people might think, oh, okay, well, the patient didn't have a problem with it. Well, I still have a problem with it. I'm not a dentist, but I care about people's teeth. So that can be a possible, other than just being annoying. Next, constipation. You could, and at its worst, I mean, first, it's annoying. If they're having it and we really need to use it, I'll often give them something like Miralax to take. But it could end up in bowel obstruction or paralytic ileus, and clozapine is the antipsychotic is the one that we worry about that the most. But with the tricyclics, also a risk. So urinary retention, it's not just that you can't pee. You could get an infection from that. You can get a UTI from that. You can cause damage to your kidneys and your bladder. And so we really do not want people getting urinary retention. It can be quite damaging. And then confusion and restlessness, so kind of a delirious effect, being confused, not knowing where you are, that's never good. And then there's actually several ocular effects. So that's effects on the eye. It's not just dry eyes, which is, in medicine we call xerophthalmia, not just the dry eyes. Because remember, we get the dry as a bone, but there's some other effects on the eye. We get, the blind as a bat. Where is that coming from? The blurry vision. So with the dry eyes and the dry mouth and things like that, you're blocking the release of fluids and mucus that keep things lubricated. You could also, get females can get dry in their genital areas. You can get dryness generally like all over the place with these anticholinergic medications. And so if that's happening to you and you are embarrassed to talk about it, tell your doctor, hey, this, I'm getting this side effect and I heard that this med can cause this dryness effect and I don't like it. Let's change it. So what are the other ocular effects? Well, we get the blurry vision and the loss of accommodation, right? That's where the blurry vision is coming. It's not coming from the dry eyes. I think that's something I used to think was that, oh, your eyes are dry, therefore your vision's impaired. It's actually not the secretion of fluids onto your eye. It's the relaxation of the ciliary muscles that leads to loss of accommodation that causes the blurry vision. So just putting eye drops on your eyes to lubricate them is not going to fix that problem. And we don't want people walking around with blurry vision, getting in accidents and traffic accidents and things like that. So that's something that you really should be worried about. And it's not through the dry eyes. Another ocular issue, there's three. Um, and this is why we have the warning. It says if somebody has acute angle glaucoma, uh, there's two types of glaucoma. I'm not an ophthalmologist. I know very little about the eye. Um, but I try to know the things that have to do with psychiatry, and this is one of them. If you have glaucoma, you should not be taking meds that are anticholinergic. Meds like antipsychotics and TCAs, we have to be really careful if they have the anticholinergic effects. This is also not caused by the dry eyes, and it's not caused by the relaxation of the ciliary muscles. It's caused by relaxation of the iridocorneal angle. I'm not even really sure what that is. It sounds like it's where the cornea meets the iris. Um, I'm not real sure exactly what the physics of what's going on, the physiology there. I'm sure there's some eye doctors out there laughing at me for not knowing what the iridocorneal angle are. And there's probably some other eye doctors out there that are just surprised that I even know that it exists, and that this is why we have the concern about the acute angle closure glaucoma. So if you've got that type of glaucoma, you should not be taking, or at least if you're concerned, consult an eye doctor. If you really feel like somebody needs to take this and they've got this glaucoma, I think it's a hard no, but if you're really intent on it, I would probably consult an ophthalmologist to ask them their opinion on that, because that's beyond what I can do. I would just be like, no, let's find something else. So a lot of eye effects. I think those are really interesting. So, we've mentioned overdose, foot stomp, foot stomp, foot stomp. There's all sorts of problems with overdose. Um, Remember, we got that delayed repolarization of the sodium fast channels. It causes cardiac and neurological effects. What effects did it have on your heart? A lot of conduction abnormalities. If you guys remember the old EKG, and you're like, oh my gosh, I'm a psychiatrist, I don't want to know about the EKG other than QT prolongation. That's all I care about. Well, with the TCAs, you really need to know this. So the PR, it can increase, the QRS can get wide, the QT can be prolonged. You can get atrioventricular block, you can get torsade de pointe, and you can get ventricular tachycardia. Not good, right? And also we can have a lower blood pressure, and you know low blood pressure. And everyone always talks about high blood pressure and hypertension, but actually having low blood pressure is more dangerous than high blood pressure. It's much more common that someone gets a low blood pressure from a medication that's lowering their blood pressure, and they're not getting that perfusion to the tissues that they need, that's going to cause a problem. High blood pressure is more of a chronic problem. It's not something that's going to cause a problem right now unless it's super, super, super high, and that's just not that common. If you have the hypertensive crisis with an MAOI, as we talked about in the last lecture, then we have a problem with really, really, really high hypertension causing a huge problem. But typically, someone can walk around with pretty high blood pressure, and in the moment, they're not going to die. But if you get really low blood pressure, you could. And so I actually worry way more about the low blood pressure, and overdosing on tricyclics can cause that. So those are the cardiovascular effects. What are the neurological effects? So mental status change, lethargy, that's like feeling tired, confusion, coma, and seizures, right? Because we're affecting these sodium fast channels are in our nerves, right? And so we're getting like impaired um, transduction of signal. Okay. Um, Also, if you overdose, respiratory depression, you might stop breathing. Those anticholinergic effects I mentioned on the previous slide. Rhabdomyolysis. So that's like if you're kind of in a tense position for a long period of time and you get some leakage of substance out of your muscles from damage to the muscles, and then that can damage your kidneys, which can cause renal failure. So overdosing on tricyclics just it can get you 20 ways to Sunday, or whatever that saying is. It can get you in your heart, your nerves, your lungs, the anticholinergic stuff, which includes like your gut, your kidneys. It's just, do not overdose on these medications. Do not give these medications to people that you think are going to overdose. um, and typically a dose of about 1,000 milligrams a day is toxic. So over 1,000, the max doses on most of these medications are in the 150 to 300 range. And so once we're getting over 1,000, which, if you're on the max dose, right, if you're taking 300 milligrams of this medication, 3 pills or four pills, and you're already at a toxic dose. If you're only taking 10 milligrams, then you've got to take like 100 pills to be at the toxic dose. But if you're at the max dose, just 4 pills, toxic dose. And someone could have like a very, they may think it's just a cry for help. Maybe they didn't really want to kill themselves. They just took a few pills. If they're on the max dose, that could be a problem. So over 1,000 toxic, over 2,000 lethal. And of course, that's not across the board. But I mean, over 2,000, that's what, like five, 6 pills, 7 pills that yeah, around 7 pills that you take of the max dose could kill you. I don't know very many medications where you can take, 7 pills out of a bottle and die. This is one of those. This is one to worry about. And so if someone does overdose, we can get blood levels. And we're going to talk about blood levels from a therapeutic standpoint as well. But blood levels can also let you know if somebody is at a toxic point, right? And in the elderly, this often can, as many things, it could take less. Okay. And let's talk about blood levels. Now, when it comes to antidepressants, getting blood levels is something we do with lithium. It's something we do with valproic acid. It's something that we should be doing with antipsychotics, but I think that's something that's maybe coming up more. But you can actually do it with TCAs, all right? And that can help you know if you're giving it for depression, which was its original intent. We don't really do that much anymore. We're not giving the depression dose, but we sometimes might. And if you do, you can get blood levels. And so what you're going to do is you're going to check the blood 8 to 12 hours after their last dose. And remember, we're checking the blood levels of the meds. So you're checking an amitriptyline level if you're giving them amitriptyline. And we want to wait 5 half-lives. So we don't want to get blood levels like day 2, right? We want to wait a week or two of them being on the meds and then check, probably 5 days, but 5 half-lives is once we get to steady state. You could check the blood levels. So levels of 500 nanograms per milliliter are toxic. And then I've got this therapeutic windows for 5 of the meds, the 5 most common used. So 4 of them have what's called a linear therapeutic window. And then one has what's called a U-shaped therapeutic window. And so linear just means straight line. The more you take, the more effect it has, right? And so the blood levels on imipramine that are therapeutic is 150 to 300, amitriptyline 100 to 250, desipramine 150 to 300, doxepin 120 to 250 nanograms per milliliter, right? That's the range. When we check their blood, we want to see a number inside of there. And so the inverted U-shaped therapeutic window is seen with nortriptyline. So that's the 50 to 150. And so interestingly here, your depression could be worse below or above. So with the linear, they shouldn't be worse at higher blood levels than that. But, once we get up to 500, we're talking about toxic levels. So we're concerned about that. But with nortriptyline, actually getting above 150 could make your depression worse. So, you know, you, which is kind of good because we don't want to give somebody more and cause side effects. So you really want to keep them inside that level. If doxepin, it says 120 to 250. If they were at 300 and they felt like it was better than when it was at 250, that could be possible. We're not at the toxic levels yet, and we've got that linear curve. So that the more you take, the more positive effect you potentially have, of course, until we get to a toxic point. So if you are using these for depression, the blood levels is something I would definitely recommend. Definitely do this. If you're using it for depression, get blood levels and put them in these ranges that I explained. What are some drug-drug interactions with these meds? All right. So 2D6 inhibitors can affect them all. 1A2 and 2C19 inhibitors, and I'll go into a lot more detail on what this means. These are enzymes in your liver, and they are what break down the medications. And so, if you've got an inhibitor of those enzymes, that can impair your ability to um, metabolize those meds, and then they're going to stick around longer, and they're going to get to higher levels. So and then the inducer would be the opposite, right? Inhibitors inhibit the enzyme from working, and inducers induce the enzyme to work more. So if you're taking a 2D6 inducer, that would metabolize the TCAs before they had a chance to work. If you inhibit it, it's going to make it more powerful, which we don't want. So we would either not want to use that 2D6 inhibitor, or we'd want to have them on a lower dose. And remember, great thing is we can check blood levels. And so as long as that 2D6 medication is something they take every day, we get those blood levels. We'll get the blood levels of what it's like when they're on that inhibitor. And, potentially you could do that, right? But if you can avoid giving them medications that interact, better to, avoid that if possible. Can't always avoid it, but if you can, try. So those are that's the pharmacokinetic interactions, and I'm going to go into a lot more detail on how the drugs are handled in another lecture as well. I know I say that a lot, but I don't want these episodes to last forever, where I go into detail on absolutely every single point. I'll bring it up, I'll explain it enough so that you can use it, but we'll have a separate episodes in the future that will go deep down to explain everything about that so that you fully understand it. So 2D6 inhibitors affect them all. 1A2s and 2C19s can affect the tertiary amines. And you can look these meds up to see, which CYP enzymes metabolize them so that you know which drugs might interact with them. And, you of course can look those up, or you can use an interaction a database system where you plug the meds in and it tells you if there's an interaction. So those are pharmacokinetic interactions. The pharmacodynamic interactions, serotonin syndrome. Like I said, I'm going to go deep into that when I hit the SSRIs. And we talked about it a little bit with the MAOIs. So serotonin syndrome, we're increasing serotonin. There's a risk. Combining medications. Don't give an MAOI with a TCA. Huge risk of serotonin syndrome. Other agents too, be careful. We'll talk about that more. And then additive effects. That's another psychodynamic interaction. So these are not effects where the meds actually are interacting together, causing, the problem. It's where, they're both causing the same effect. So if you're taking an anticholinergic TCA and another anticholinergic drug, then you're maybe going to cause more anticholinergic problems. So be careful about that. If you're giving another medication that lowers blood pressure and a TCA, that could be a problem, could lower it even more. If you're giving them a sedating medication and a TCA, that could be a problem, even more sedating. And this next slide, I just want to, I've talked about all these bad points about TCAs, but when would we actually want to use these? right? Like we don't, we used to use them all the time. They used to be pretty much all we had, but what would you use it for now? I mean, one thing would be if you've tried other things and you're like, oh, the top three things didn't work. Let's try something fourth line. Of course, you could have it lower in your pecking order of your algorithm. But are there some specific conditions where you might want to pick it first? And there are. So melancholic depression is one, and I'm going to go into detail about that later, about what that is and what all the kind of rank order, what I would use to treat that. But TCAs is towards the top of the list of something to consider for melancholic depression. Antidepressant augmentation. And so this is, they're taking, maybe they're taking an SSRI and we want to add something to it to get more effects. So TCAs is something, we're going to go through all the augmentation meds at the same time, but this is a med you could use. Nortriptyline has kind of been shown to maybe be the best augmenter, maybe because it's better tolerated. But some of the SSRIs are 2D6 inhibitors. I'm talking to you, fluoxetine and paroxetine. So I probably wouldn't want to combine those with the TCAs because, I don't want to increase the TCAs even farther. But if you did, you'd be wanting to use lower doses. Another one is if someone gets ECT, electroconvulsive therapy, after that, to prevent a relapse of depression, the top recommendation is actually nortriptyline plus lithium. That's an unusual kind of combo idea, but it's been looked at, and that's the recommendation after ECT. So consider that in patients getting ACT. And then all the chronic pain stuff, and mostly amitriptyline. If they've got headaches, neuropathic pain, fibromyalgia, migraines, neck pains, low back pain, these are things that you might want to consider. And what you're going to see is primary care uses them a lot. And so primary care, if you're out there listening, thank you. Be careful. We don't want to cause those anticholinergic effects, but you'll see that. And so psychiatrists, you guys need to kind of be aware that other doctors are using these meds for these other purposes. So also, and depression with IBS. So inflammatory bowel syndrome is a notoriously difficult to treat disorder, as are the chronic pain disorders. And some people think, oh, just giving the antidepressant helps, because really this is just a somatic manifestation of a depression or anxiety that they don't realize they have, right? But it, it could be that this actually helps with the actual disorder, because that norepinephrine that a lot of them are increasing the effects of, or that's helping with those nerves, right? Norepinephrine is used in nerve conductions for a lot of these, so the sympathetic nervous system, right? Those alpha and betas, right? The sympathetic nervous system, the autonomics. And so there may be some reason to think that, the SSRIs don't really affect the norepinephrine system. And so TCAs do, some of them more than others. And so that's why, maybe they may be more effective than an SSRI for depression with IBS. And then, of course, OCD. Clomipramine is not first line. I've had several patients with OCD. I've offered several of them clomipramine. No one's ever wanted to do it after I've told them what to expect. SSRIs are first line. Clomipramine may be a little more effective. The problem is we don't have the head-to-head trials. It's just more that clomipramine's been around a long time, and it's only used for OCD, and so there's just more evidence out there that it helps with OCD. So, is it more effective than SSRIs? Maybe. If someone fails SSRIs, should you consider it? Yeah, sure. But I would use a SSRI first on OCD. And then insomnia, trouble sleeping, low doses of these meds. In fact, the doxepin has an actually FDA approved indication for sleep problems. And this is probably what I use them for the most. I will frequently go to a TCA at a very low dose for insomnia. And then treatment resistant depression. So that was where I mentioned at the beginning. So you've tried a lot of other stuff. In head-to-head trials, they don't really do better than the SSRIs, SNRIs, etc. But, different meds work different for different people. Um, the the studies that are out there show that they are better, but they're older studies. The patient populations are not the same. We don't really have the head to head. But at the same time, if you've tried other things and it hasn't worked, try a TCA. So I like to summarize, I like to do my advantages and disadvantages and so for TCAs, advantages, they're cheap as heck. They've been around forever, so they're super cheap, long history of use. And what that tells us is we know what to expect from them. We're not going to get surprised that someone's going to get some weird adverse effect that we've never heard of. There's a lot of bad effects that we get from these meds, and we pretty much know what they are. So you kind of know what you're getting yourself into. So that long history of use. They were successfully used for decades because they were all we had. So we do have that track record with them. The fact that we can check those therapeutic blood levels, that's awesome. We can't do that with any of the other antidepressants. I can't think of any that we can do other than the tricyclics. So that's really cool. And then the insomnia. If you remember earlier, insomnia is a symptom of depression. A lot of people that have depression have insomnia. Oh, wow, here's a med that I can give for both. So, that insomnia effect is to help with that is great. And then the neuropathic pain. So the fact that they can help with those neuropathic pains, those are the advantages. The disadvantage list, a bit longer. Lethal and overdose, cardiotoxicity, lowering the seizure threshold, all the adverse effects, and then the fact that we remember all those anticholinergic effects we have. Well, there's conditions that people could have where it's bad to cause the anticholinergic effects to begin with, but then there's folks that have conditions by which causing those effects could make them even worse. And so if you have enlarged prostate or glaucoma, or you're an older person, or you take a lot of other medications, not great with TCAs. Okay. So the elderly, children don't really, they're not approved for use in children other than the enuresis. They actually are approved for depression, but I mean, I don't know anyone that uses these at all. Like in adults, I see it. In kids, I don't. But I also, as a adult psychiatrist, don't. I have my number of children that I've reviewed their records or seen is pretty low, but I have never seen a child on a TCA. And then the elderly, you could do it, but it would be very, very low on my list just because the elderly being susceptible to delirium and constipation and all those effects are just um, way more likely to get that stuff. And so I would, I do not, I see it, and if I have a chance, I remove it. I have taken TCAs off of elderly patients that I've been consulted on, and they've completely turned the corner. They were a zombie and they became alive again. So really try not to use these. And if you do see it and you're seeing a lot of they're not, they're thinking slow, and they're losing their balance, they're falling down, they're getting a lot of injuries. I had a lady, she was on a ton of meds, and all we did was lower the amitriptyline, and within days she was a totally different person. And I was like, wow, just the amitriptyline, even though she's on 6 other psych drugs that I'd also like to peel half of them or more off. But that was the one that really that was the one I was like, that's the one we should target first. And it was a big difference. The weight gain, we talked about sedation, but we've also got weight gain with these medications. And then the 2D6 issue, right? It's because the TCAs are so dangerous to be at increased levels. So if you inhibit a lot of other meds, you're going to increase the levels and people are going to get more side effects and are not going to be happy with you. But you increase a TCA, you could kill a person. And in addition to the inhibition of 2D6 being a problem with other meds, 7% of the population has reduced activity of 2D6 at baseline. And so giving them a standard dose of a TCA is like giving them a super therapeutic dose, too high of a dose, right? And unless you've done psychogenomic testing, you're not going to know if they have that reduced 2D6. And 7% is a lot. I'm going to talk about the psychogenomic testing a little more later as well, but this is a big one to really see its impact. And then, of course, the anticholinergic effects. I can't stomp my foot enough about that. And then um, also, I know I said let's use it after ECT, but don't use it during ECT, because remember, it affects your seizure threshold, and we don't want to take meds that affect your seizure threshold. I mean, I would, if you're on it, hold it, then do the ECT, then go back on it, because we don't want the seizure threshold toyed with when we're trying to induce seizures. It's generally makes it more challenging to control the seizures to give the effect that we want. So don't give with ECT. All right, man. I know we've been going for a while. These last few are going to go pretty quick. I'm going to hit every one of the TCAs and kind of go over their specific points. So the tertiary amines first: imipramine, tofranil, 1959. We're looking for a new H1 blocker. We found it. Its name, imipramine, it actually comes all that. That's another cool thing about the TCAs is that their names come from their full name. So the full name of imipramine is imidapropylamine. And so you kind of take some of the letters in there and you squeeze them together, it becomes imipramine. It's FDA approved for MDD and pediatrics, depression, and enuresis, used off label for functional dyspepsia, IBS associated pain, chronic neuropathic pain, and ADHD. Next, amitriptyline, Elavil, 1961. It's the most anticholinergic of the TCAs. It is very similar chemical structure to imipramine. Its name comes from aminotriheptyline, amitriptyline. It's only approved for MDD, used off-label for pain, GI discomfort, headaches, neuropathic pain, insomnia, sialorrhea, drooling. And another interesting point, it actually used to be combined with chlordiazepoxide, the benzodiazepine, and the combo pill was called Limbitrol from 1977. This was like a combo depression and anxiety pill. And I actually stumbled across this, and it was withdrawn from the market in 2023. But when name brands are withdrawn, generics could still be out there. So just so you're aware that this is actually a thing, that the amitriptyline chlordiazepoxide combo pill Limbitrol, it's a generic that could be out there, but the name brand was just taken off the market and approved for depression and anxiety at the same time is what that med was. Next, doxepin, Sinequan, 1969. So it comes from the oxepin probably is talking about the oxygen ring, and the D at the beginning might refer, I'm guessing, to di, referring to the other two rings, because you've got the oxide ring and then you've got the other two rings, because it's a tricyclic. I'm not sure. I'm kind of guessing there. I was trying to figure out where that name came from. Approved for, remember we went over this before, MDD, anxiety, the depressive episodes of bipolar disorder, they're not recommended. And then the insomnia, which I mentioned, the actual brand name of that's Silanor, came out in 2010. The interesting thing here is the lowest dose of doxepin is actually 10, but Silanor is in 3 and 6 milligram pills given before bedtime. I give people the 10 of doxepin, because, and I'll tell you why in a second, right? So the branded Silanor is $22 a pill. Holy freaking crap. Per night if you're having to take it for sleep. But then when the Silanor branded product went off the market, the generic 3 to 6 milligram doxepin pill came out, $4 to $17 a pill. How much is doxepin 10 milligrams? 30 to 70 cents a pill. No insurance company is going to argue with you. You can go ahead and give doxepin 10 milligrams off label. And, with a lot of things, they're going to be like, hey, we're not paying for this. But if you're trying to give someone a 30-cent pill, the insurance companies aren't going to care. But then the important thing to be aware of is it's only FDA approved for insomnia at the 3 to 6 milligram dose. But and the problem is that the 10 you can't cut because it comes in a capsule. But what I found is that nobody's over sedated on 10 milligrams. I think I've only seen it one time that the 10 was too strong. In fact, I usually tell people take 10, 20, or 30, which means take 10 the first night, try that a couple nights. If it doesn't work, go up to 20. If that doesn't work, go up to 30. If that doesn't work, come back and see me. We're still not at a high dose, but we're at a high dose for trying to help you sleep. I've gone up to 50. I've had patients on 50 milligrams of doxepin primarily for sleep. But at that dose, you're starting to get some depression, antidepressant augmentation going on as well, which is nice. And doxepin is one of those that has kind of lesser side effects, which is good. But if you really want to give lower than that 10 milligram dose, you could open the capsule or instruct the patient to open the capsule and, kind of measure out half or dump half on a thing and use a knife and divide it out and just take half of it. And that'd be 5 milligrams. So you could, it's not one of these some of these meds, if we open the capsule, it like changes the way the med works in your system. For this one, they've just put it in a pill capsule form to be a pain in the butt, I think, um, because you can't split it. But of course, the capsule's been around forever. But regardless, they don't make a splittable version that you could use for sleep. But open it, take half, or just take the whole thing. Um, this is what I tell people for sleep, and we'll go into this in depth in the insomnia lecture. But you can really finagle the dose and the timing to get that sleep right. So Silanor for insomnia, but then we've got Prudoxin or Zonolon, which I've actually never seen or even heard of until I did more research. That's the formulation of the doxepin branded product that's used for the topical for the pruritus or the itching on the skin. It's actually approved for 8 days of atopic dermatitis or lichen simplex chronicus. Those are the two conditions that you can give it for. And atopic dermatitis is one of the most common reasons why I'm not a dermatologist. Um, and I find the skin to be one of the more challenging aspects of medicine unless you like really see a lot of it and learn a lot. So um, I'm probably not going to give this, and I'm guessing most dermatologists are giving something else, but it's out there. And then one last point on doxepin, it increases Ramelteon by 66%. And Ramelteon it's a melatonin agonist that we use for sleep. So, oftentimes people's sleep is so poor that they're taking more than one medication to help sleep at once, even though we like to avoid that at all costs, if at all possible. But if Ramelteon is the pill that they're combining with doxepin, just be aware, 66%. Another thing about doxepin is and I think I'm going to hit this a lot later when I talk about pregnancy. It's actually one of the big, it's one of the ones that you really don't want to take with pregnancy or breastfeeding. I think it's breastfeeding. It really gets into the milk a lot, and so it's the highest level of warning. It can cause sedation in the baby. So I should have probably put that on this slide, but we will talk about that later. Out of all of them, this is the one that you don't want to breastfeed on. Next, trimipramine, Sermontil, 1979. Name comes from triimipramine, basically three methyl groups on with imipramine has two, it has a third one, so it's tri three. Approved for MDD. Um, I've never seen this used. This is I've never given this. This is the first one that we've talked about that I have not ever given to someone before. Um, and I don't know why. I'm not really sure because I haven't had experience with it. I'm not sure when I would reach for it because it's actually relatively weak on the serotonin and norepinephrine reuptake pumps, and most of its effects are on the receptors that cause the adverse effects. So, like I said, haven't seen it. Next, clomipramine and Afrinil, 1990. Clomipramine, chlorimipramine. It's got a chloride group on the imipramine. It's the most serotonergic. There is talk of using it with a 1A2 inhibitor like fluvoxamine, Luvox. If you really have a bet, because Luvox is another med that's approved for OCD, and I'll go into all this OCD stuff later. But be very careful if you're going to give a 1A2 inhibitor with clomipramine. This is going to give them a huge effect. So be very cautious. But I've read Stahl's book, that this is something for the expert that's very, very comfortable with it. This combination could be used. Um, the metabolite of clomipramine is noradrenergic, and that makes up 2/3 of its noradrenergic activity. It's only approved for OCD, and it could be used off-label for MDD and panic. Um, Next, secondary amines. So desipramine, norpramine, 1963. This is the metabolite of imipramine, and this is a kind of a cool thing. So desipramine. So that's short for desmethyl-imipramine. Desmethyl means take a methyl group off, and that's generally often how things are metabolized. They get metabolized and metabolize basically means we're changing this drug into something else. Typically, it's the liver is doing this to give us, to be able to get it out of our system. We metabolize it, we change it into something that we can excrete in our urine. And sometimes when we metabolize things, we turn them into an active metabolite, which means it's a metabolite, but it also is an active drug. And so when you give someone imipramine, you're also giving them desipramine. Um, and sometimes it's the active metabolite that's the effective one, but in some cases, it's both the parent compound and the metabolite that both have effects. So you're getting both effects. I'm not sure if imipramine has its own separate effect, but its active metabolite desipramine does. And desmethyl means demethyled. Okay. It's approved for MDD, off-label for neuropathic pain syndromes. And the good thing about desipramine is it's the one with the least amount of adverse effects out of all the TCAs. Least orthostasis, least sedation, least weight gain, least sexual side effects, least anticholinergic effects. And so if you're looking for a TCA that's not going to cause a bunch of side effects, desipramine, maybe that should be high on your list. Next, nortriptyline, Pamelor, 1964. It's a metabolite of amitriptyline. Okay. And this is confusing. I know I said desipramine with desmethyl means that's the naming convention for a metabolite, but nor also has a similar meaning. And there's a lot of nor drugs out there. Norquetiapine is the active metabolite of quetiapine. And so what does nor mean, right? Nor is short for normal, and it's kind of was like, this is like decades ago, right? It was described as the state where the amine has been completely demethylated. So your compound has gotten as many methyl groups off of it as possible. And so it's now in the normal state, and it's called nor plus the name of the parent compound. So nortriptyline, noramitriptyline is the full name. But if you look at nortriptyline, you'll notice there's still one methyl group left. So sometimes nor is used for just demethylating once and not taking all the methyl groups off. I know that's confusing, and I know maybe a lot of you are probably not interested in this. It's like, why do I care? Why do I need to know? And you don't. I think it's interesting, and it actually helps me remember what these drugs are and what they do and what they look like. And it just helps me with memory to kind of know what all these like prefixes and suffixes and like where it comes from, what the history behind it is. I have people tell me, they're like, I don't need to know the whole story. And it's like, oh, but that's how I think. And so I'm hoping that like those of you that think like that are attracted to this podcast. You're like, I think like that too. Thank you for explaining it to me. In med school, they didn't really explain that. They didn't tell me what that meant. And now I know it all. To me, when I learned this, it's like, now I know all these other things that I, didn't even think about. Oh, that's what that norm meant on that compound and that one and that one and that one. Oh, and now that makes sense. And it's the active metabolite, blah, blah, blah. So, um, I think for some people, the way their brains work, that could be helpful. But if you don't care, throw it in the old garbage pile in your brain because you don't need to know it to know how the meds work. So nortriptyline, approved for MDD, off-label for neuropathic pain syndromes, headaches, and smoking cessation is listed, though I've never seen it. I don't even know how that would work. And like I said, never seen it used, but I like to be thorough. Um, and then also it has less side effects than the tertiary amines. So less orthostasis, less sedation, less anticholinergic effects. So this is, other than disipramine, nortriptyline may be another one you might want to reach for. And then lastly is protriptyline Vivactyl 1966. So it looks kind of similar to nortriptyline. There's the double bond is in a different part on the ring. Its etymology comes from propyl triheptylene. So that's because it's got a propyl amine hanging off of the heptyl ring. Once again, something that I like to know that helps me understand things. Hopefully it helps other people. But and then you shorten propyl triheptylene and you get protriptyline. All right. So I've never seen this used. I've never used it myself. I've read that you could have there might be a more rapid response to this one. I'm not sure why. This is the one with the longer half-life, the 54 to 92 hours. It's the most anticholinergic, and like I said, rarely used. Haven't seen it. I haven't been around long enough. I'm sure those of you out there that are, been practicing for 30 or 40 years have seen these that I haven't. And then just to kind of finish up with tricyclics are the related tetracyclics. And so I've just got one slide on these to just kind of slam through them. So what are our tetracyclics? We've got meprodoline, brand name Ludiomil. I'm not even sure how to say that. Came out in 1974. And one reason I don't know how to say it is because it's not available in the United States. I think Canada's got it. And I had heard that there's a way of ordering it from Canada, but that, it doesn't really work any better than anything else. So, comment down below if you love meprodoline and you found a really good use for it, and clue the rest of us in. Next tetracyclic, amoxapine, brand name Ascendin, 1992. This is an interesting compound because it's an active metabolite of loxapine. So loxapine, amoxapine kind of sounds similar. And the interesting thing is loxapine is a first generation antipsychotic. But amoxapine actually has significant 5-HT2C blockade, making it more similar to a second generation antipsychotic. And so when you take loxapine, you're getting a first gen and a second gen at the same time, sort of. And the interesting thing is, even though it's in many ways an antipsychotic itself, as it blocks D2, it is only approved for major depressive disorder. And one thing you might think about, and I don't know that there's any studies on this, but like if you've got a patient with major depressive disorder with psychotic features, that maybe, I've never used amoxapine, never seen it used. I like to be honest on the podcast, like what I have experience with, what I don't, what I, read extensively about, what like meds like this, or things I know less about, like ophthalmology and dermatology. I want to be upfront. Let you know, I have not done everything that everyone else has done. My hope for this podcast is that you're learning in a new way that works for you. I wish I had more experience, but I only have as much as I have. But I feel like I'm teaching in a way that's different, and hopefully a lot of you are finding that helpful. So, the idea of using this, because often with MDD with psychotic features, we add an antipsychotic. And so, hey, maybe this is a good idea because it's the only antidepressant that isn't, purely kind of an antidepressant that has an antipsychotic elements as well. Some of the antipsychotics have antidepressant features. And so that might be a reason to use those because they have kind of both. And we'll talk about that a little later as well. So, the other thing, the fact that this is a D2 blocker means that you're going to get different side effects with this one than you're going to get with the TCAs. You're going to get dopamine blocking side effects like EPS and NMS, neuroleptic malignant syndrome, right? Those are things that to look out for. Next is mirtazapine, Remeron. I'm going to talk about this later when we talk about atypical antidepressants because it is a tetracyclic. If you look at its ring structure, it 100% is, but it's also classed as a noradrenergic and specific serotonergic antidepressant. So I'm going to talk about it, and it's also very commonly used. So we'll talk about it when we talk about the atypical antidepressants in a lot more detail. And then just to kind of throw these out there, some other compounds that have tetracyclic ring structures, meancerin. This is another kind of meprodoline. This is like, this is an antidepressant that's approved in Europe, but not in the United States. Name brand Tolvan. If you're from Europe and you love meancerin, comment down below. Tell us how much you like it and why. And then some other meds with tetracyclic ring structures, quetiapine. Hey, quetiapine's approved for depression. It makes sense. It's a tetracyclic ring structure. It actually kind of looks like an antidepressant. So it's kind of similar to amoxapine in that it blocks dopamine in addition to some depression receptors as well. Though quetiapine is not a strong D2 blocker, and we'll talk about that later too. And then lastly, loxapine. So the parent compound of amoxapine also has a tetracyclic ring structure, which makes sense because the metabolite is just, a tiny change. So loxapine and amoxapine look very similar. So loxapine also a tetracyclic ring structure, though I can't call it a tetracyclic antidepressant because it's not FDA approved for depression. So that wraps up the tricyclic and the tetracyclic antidepressants. And we talked about a lot of stuff. We talked about the receptors in the brain. We talked about overdosing on these being dangerous. We talked about anticholinergic stuff a lot. And so even if you're not going to use these meds a whole lot, there's just a lot of that information that this kind of surrounds these meds is going to apply to other meds we're going to talk about later. And so these concepts are really important. And these meds are used frequently. They might be, 50, 60 years old, but for their FDA approved indications, not used that often. For the off label stuff, used a lot. Primary care uses these a lot. So very important to know them and very important to kind of know all this I think most people, they don't know this many things about the tricyclics. They're like, oh, that's used for chronic pain or that's used for sleep, and they just kind of use it. But I think having this thorough knowledge of, and I hope I explained everything you could ever want to know about tricyclics, right? Hopefully that's helpful. you know I'm hopefully that helps you to better understand them. So that's going to end our lecture, and I will see you next time.